fellowship that would train a pharmacist to go that route. Because a pharmacist that completes the 4 years of pharmacy school, whatever they did preceding pharmacy school, they don't need a residency to work anywhere. Okay? About 60% of pharmacists still go the community route. Okay, they still go the community route. And right now, there's probably not a big reason to do a residency for community. There are community residencies out there for pharmacists. Most of what they do is they learn to bill for medication management services, immunizations. Immunizations is a big deal. So we'll do this little quiz. So what can pharmacists do right now on their own in South Carolina as far as immunizations go? Flu shot. Anything else? I heard of shingles. Or at least the of shingles. I hope that's what it was doing. Okay, so flu shot is all they can do, no prescriptions, walk in, it's October, I need a flu shot. If you're an adult, okay? If you're an adult. Shingles, pneumococcal, okay? So strep pneumo, meningococcal, or Neisseria meningitis type. Those can be given by pharmacists under the privy of prescription from a physician, nurse practitioner, etc. We're working right now to see, why can't a pharmacist do shingles? Why can't a pharmacist do Tdap? Shingles is crazy because a physician can't bill for shingles in their own office. If they give a zoster vaccine, Zostavax, they can't even bill for it with Medicaid and Medicare. So Medicare, all the elderly patients that need a Zostavax, if you do it in a physician's office, can't even bill for it. Makes no sense. Makes no sense. But a pharmacist can't get it. Unless you have the prescription, they got to go multiple places and this and that. It's really weird right now. So we're actually working on a solution to this to see, what if a pharmacist could partner with a health system or with a physician practice and have a blanket. All of my patients can come over and get Zostavax at your pharmacy. All of my patients can come get Tdap at your pharmacy. That makes a lot of sense. So we're working on some of those things right now. Yes, sir.
I know it's a preconceived notion that community pharmacies like Walgreens or CVS, all they do is dispense medication. Mm-hmm. Could you elaborate on what else they do?
Sure. So it is a preconceived notion that it's this lick, stick, count, whatever else is in the mantra there. Fortunately, that has shifted a lot with some of the rules. Let me tell you why that was like that. There's actually rules in the pharmacy board that how many technicians can actually be in a pharmacy at the same time as a pharmacist. So the old ratio was 1 to 2. So you could never have more than 2 technicians with one pharmacist. Well, a pharmacy's not going to pay another, however much $1,000 to bring in a pharmacist to be there. So you just had to work in a very technical role sometimes because you only had 2 technicians there. Well, now that has changed to a 1 to 3 ratio, especially when you have a pharmacy intern who's a pharmacy student or a certified pharmacy tech. So now you've allowed pharmacists to shift out of some of those technical roles. The technology has also helped that a lot. You think about a pharmacist or you think about a nurse as the last line of defense in the hospital for a drug error. Well, pharmacists in the community, they're going to fill 300 to 400, sometimes 500 prescriptions in a day in an 8 to 12-hour shift, and see somewhere between 300 and 400 patients that come into that door. That's a lot of access to patients. That's a lot of counseling that happens there, and very little goes noticed, to be honest with you, of what kind of impact they truly have. Great story I have about a pharmacist from when I was in Winston-Salem. There's an HIV medication, you don't have to remember it, but it's called Rayataz. I'm not supposed to be here teaching on it, but it's called Rayataz. Okay, this drug requires an acidic environment to be absorbed. Does the stomach comply with that?
Yes.
Is the stomach acidic? Yeah, okay. Stomach's real acidic, so easy absorption. How many of you have heard of Prilosec? Okay, proton pump inhibitor. You inhibit proton pumps, you change the acidity in the stomach, and now your pH goes up above 5 in most patients. Well, we've got a guy who's been on HIV meds for 6 years, on HIV meds for 6 years, undetectable virus, doing great. He's married in a serodiscordant relationship. His wife does not have HIV. They've been married for 5 years. She's never gotten it, which is very plausible if he is completely undetectable and takes his meds as is. He's on this drug Rayataz. His primary care physician, unbeknownst to him, he comes in complaining about GERD, acid reflux, and he says, yeah, just stop by over the counter and grab some Prilosec. That'll help with your GERD. I don't know what clicked, but he took the drug for about 2 weeks, and he read on the back of the box that it says, should not take Prilosec for more than 2 weeks. And for whatever reason, it prompted this patient to go ask the pharmacist, who happened to be our outpatient pharmacy at Wake. They said, hang on before you take any more. They called us up in the clinic and said, should he be taking this with this drug? He said, absolutely not. We actually got him back up into the clinic, and he now had detectable virus after only 2 weeks of taking the drug, because it was inhibiting the absorption of one of his HIV meds, so he was not fully suppressed anymore. He was very fortunate that there was an intervention there by that community pharmacist. It just so happens that it was in a Wake Forest clinic, but it was, for all intents and purposes, it's an outpatient pharmacy. People come in and out of there from wherever to have their prescriptions. We don't have the same kind of success stories to say that. I know 100% fact of a patient that transmitted his virus to his wife for the same exact scenario. He was on the proton pump inhibitor for 6 months with that drug. 6 months. And he transmitted the virus because nobody asked pharmacy physicians, nobody asked what over-the-counter meds you're on. And if they did, that's a very delicate disease state, and sometimes it's an educational thing. That's why we have specialized people to take care of it. That's why we have ID physicians. That's why we have HIV-trained pharmacists, etc., to take care of that stuff. So there are a lot of things that pharmacists do in the community. Allergies is a huge one. Drug-drug interactions is a big one. Believe it or not, patients are not real honest and forthcoming. They're not at all. There's a big movement now to get community pharmacists into physician practices. It's called a patient-centered medical home. A patient-centered medical home. And so these chronic disease states, a physician diagnoses them with high blood pressure or high cholesterol, gets them set up on some meds, maybe in consultation with the pharmacist and the patient, and then instead of coming back to the physician every 3 to 6 months to have things checked up and adjusted, they now get them set up with the pharmacist in their clinic to take care of their chronic disease state. And then if everything's A-okay and checks out, they continue on. If there's something acute, then the pharmacist can triage that and give it back to the physician. The physician can see more patients in a day now, many more patients in a day. They can continue to accept new patients, which is sometimes difficult in a practice. And then you have the pharmacist who's able to manage chronic disease states with these chronic meds. So that's a big push right now that you're going to see because of the big shortage that's coming in primary care physicians and the aging population that you'll continue to hear about probably till you're 50. That's what everybody's talking about now. But that's one of the movements you're going to see over the next few years, this patient-centered medical home, kind of getting the pharmacists maybe out into these physician practices, which is kind of a cool thing. Kind of really cool. What else?
Well, there's like a lot of people on pre-med, so if you went the pre-med track versus pre-pharm and you decided to do the infectious disease residency, like what are the differences between your pathway and like let's say some of the interns that follow you?
Okay, so if you went to medical school, okay, if you go to medical school, you'll then complete a residency. You'll be in residency 3 or 4 years following medical school. Okay, infectious disease specialty is in a fellowship on top of that, which would be a 2-year fellowship. So you're looking medical school, and then when you finish the 4 years residency, 2 years of IV fellowship, then you will be an infectious disease physician, infectious disease trained physician or doctor.
So it's a little bit, obviously, different track because ours is all squished in. We have 1 year of general residency, and you have 4. And we have 1 year of specialty or 2 years of fellowship in infectious disease. So we're looking at more 3 years post-grad. We're looking at 6 years post-grad. Some people, before they would do an infectious disease fellowship, might work and have a year under their belt. Maybe they serve as a hospitalist for a year and then go into a fellowship so that they even have some practice under them. They also, it makes them more competitive for the more competitive fellowship programs in medicine as well. That's something that you'll see. Actually, one of the ID fellows I trained with at Wake Forest, he was a PharmD before he went to medical school, and now he's an infectious disease physician at MUSC. And it is really cool. It's kind of a neat perspective. A PharmD MD has a really cool perspective on it, as you might imagine. It's pretty good training from a clinical perspective for sure. What else, y'all? Have I been filmed this whole time?
Yeah.
That battery is, that's awesome. All right, well, I will, I'll be glad to send my contact info. You can send it to the group. If y'all have ever any questions, if you end up sticking around here for medical school, interested in learning about any of the research stuff that we're doing, I'll be more than happy to talk to you about that. I love working with medical students and medical residents. It's a really fun part of my job. I like teaching. I mean, teaching and research is probably code number 1, and then being an infectious disease pharmacist is below that. So they kind of go hand in hand, but I really do enjoy that. So I'll send all my contact info out, and anytime I can help, I'll be glad to help y'all